what I'll do is, unless George or Javier want to say something as an introduction, I'm ready to jump into some slides and sort of get to the meat of what I think we're supposed to do.
I think jump in.
All right. I'm not sure. Hold on a second. Let me share desktop 3, share. Okay, you can see this intro slide, right? Everybody see the slide? Yes?
Yes, yes.
You see it.
Okay, great. Okay, so again, as I mentioned at the start, our goal here is really to discuss some topics that will hopefully turn into some recommendations coming out of the workshop. As anybody who's been on this workshop knows, over the last 18 years, our challenge during these technical and otherwise, these breakout sessions is to come up with recommendations. So again, we don't have the benefit of actually seeing our session or sessions that are happening tomorrow. So what I did was I put together a couple slides, and I'd like to just get feedback on those slides. And you may have seen some questions also for each of the sessions, and we'll cover those as well. So let's start with one of the first things. You'll hear a talk by me in the first panel of session 5 tomorrow. And I will discuss one of the main issues that we've run into lately. And that is that there are no general international standards for measuring the resolution of CT scanners yet. And remember that MTF is basically a frequency domain representation of resolution typically done in plane. And it's usually reported as the 2D in plane resolution. So it's also important to let everybody know that each scanner vendor typically has a unique set of CT image quality phantoms. So they don't tend, each vendor says, well, I measure it this way and the other vendors measure it that way. And there's no accepted resolution measurement methods from 100 millimeters, let's say, out to 200 millimeters. So out in the periphery of the scanner. So the first thing I wanted to bring up with this group and discuss is a proposed recommendation, which you can read down here, which is that an open science, collaborative, constructive, data-driven, and pragmatic initiative is started to create a 3D resolution, and there's other related image quality measurement standards led by a multidisciplinary group of engineers, scientists, and physicians. So first questions to folks, how do you feel about this technical working group here coming up with a recommendation of this type? Javier, George, I know it impacts George's research quite a lot.
But Rick, when you make that comment, just to be clear, you are referring that there is no an FDA approved approach to measure resolution, or that there is no guidelines whatsoever, because the AAPM has put guidelines on how that has to be done. I agree. Those can be limited to in a scope, but yes, I mean, I think we might want to frame this, a little bit in the proper context, because we might wrap people the wrong way, in different, in the medical physics community.
No, it's true what you said, that the AAPM does provide documents like the working group 233, but those are not accepted by the scanner vendors. They don't follow those recommendations. And secondly, they're not specific enough. So again, we're working at a deficit because we haven't had a chance to see any of the technical presentations. Yes, there is no accepted standard right now for measuring resolution in CT scanners. And There's a lot of discussion about different ways of doing it, but there's no standard.
Rick, do you have a definition for resolution? Is, my classic understanding is resolution is the finest, if you will, frequency, or the smallest step that you can resolve. But don't we also want to consider precision in some sense, as that, as we know, that there can be a distortion, much greater distortion, for example, in MR, but there can also, with cone beam reconstruction, be distortions in the location of where the pixels are resolved, as well as the spacing between them.
Yeah, so dimension, basically the linear, basically accuracy in terms of distances should have, we expect a regular rectilinear grid within a CT scanner, and we know we've measured distortions of that grid. We call it spatial warping. That's another set of things. What we'd like to point out, though, is so I just wanted to see if we could focus on this issue of resolution. Resolution is probably one of the most important image quality metrics of any optical system, CT included. And so the first question here is, does this group agree that we should try to come up with, we as in globally, the community, should try to come up with a three-dimensional resolution image quality standard? I'd like to see if we can focus on that just for a moment.
So,
George?
Yeah, so Rick, maybe I'll preface this by saying I do think that we need to come to some standards, but part of the thing of enacting these is having a group or community coalesce around a need. And I understand there's the chicken and egg, well, better resolution or standardized resolution, we can monitor disease, we can maybe enable new observations and therapeutics. But maybe I would even push back now and look at Javier, I'd look at Francine, or I apologize, maybe any of the other sort of clinical consumers of this, and say, what are you not getting that the technical community needs to provide, right? Because Rick, I think part of what drives this, I agree with you, there has to be technical standards, but there needs to be a clinical need around it too. Well,
The fact that there is no standard means that it can change at any time, including when you lower radiation dose, and we have no recourse. There's no way to if you believe the resolution was not proper for any study that you do, there's nothing that you get from a vendor or from anybody that says that's what it should have been. So we're living in a world, literally a Wild West world, where you can be delivered any resolution. Now, it's not that bad. It doesn't have, but we have tons of examples of problems with losses of resolution that we were not expecting. And you have been living with that variability for our entire lifetime of CT. And so it probably feels like this is normal. Why should we worry about this? But the truth is that it's a lot of variability, and it does impact your volumetric measurements. It does impact your your airway wall thickness measurements. It probably does also impact your emphysema measurements.
So George, to answer your question, I can only say that when I've been hearing you and Tony and Rick talk about this for the 18 years that Rick has reference to. And, I trust the technology. I look at CT scans as a pulmonologist every day, and I trust what I'm looking at. But when I talk to Rick and to all you guys, I wonder, I'm starting to hear about problems with resolution, et cetera. So I can't answer that question. I don't know what is missing. I really trust what I get. And my question is, why in these 22 years now that we've been meeting with lung cancer screening stuff going on, why haven't the vendors gotten together and come up with a consensus? What's the problem? So even if we do come up with recommendations, is that something that's going to happen? Or are we just going to write up a nice recommendation and that's it? I mean, that is very concerning from the point of view of a clinician. I don't know if other clinicians in the group would agree with this.
I was invited to speak, and I think I will speak my piece. The issue for me, and I think I want to point out, and maybe it's why we're accepting of a variability of data. Thoracic radiologists generally read CTs, MRs, and portable chest x-rays. And we read the portable chest x-rays by the 1,000, which are probably one of the most variable and useful if you have multiples. But what I'm looking for is something that's in the workflow that triggers the radiologist to do a better job in communicating with the pulmonologist and the patient. I'm not talking about perfection or necessarily doing a great job. Sometimes you've done something better by motivating the patient to stop smoking, even though you may not be so quantitative. When I started working in this area with people, our radiology reports had Zippo in it for emphysema. People could have horrible emphysema and airways disease, bronchiectasis, it didn't matter. It rarely made it into even the clinical report. Sensitizing the radiologist to consider reporting it on a clinical basis. And if you use the visuals that we can get mainstreamed into arrive with the study, they are things that I think provide a global picture. One of the sponsors of this conference is InBio, and they've been working with Chuck Hatt for quite a while over the idea of having visual representations that are appropriate for patient motivation. The idea that if someone's gaining or losing lung volumes, we tend to do a lousy job with it. So if we improve the radiologist's ability to do for the pulmonologist something by a percentage, I'm not looking for perfection. If you think about the patients, well, actually, I'll make one little joke.
Francine,
Yeah.
We're really mostly focused here on CT images for measuring lung nodules. And the lung nodules are between 6 and 10 millimeters in size. So resolution plays a huge role. And I understand
Not as huge a role as you want to say. It
No,
makes
I
more
am
difference whether
telling
they're
you,
increasing in size than what the absolute size is. This is why I'm sort of trying to defend backing off of your perfection, and it applies equally to the nodules. If I had to say, what do I want better definition of solid versus subsolid and non-solid nodules, which is difficult.
And we're working on that, and we have
Okay.
but again, I just want to point out that we have no standards for resolution, and it can change at any time, and it can change in very bad ways. So either we agree to have a recommendation around this or we don't, and then we have to move on.
Rick,
No.
I would say, I would add that we should not focus only on lung nodules. I think one of the main objectives of this whole symposium is to talk about other findings other than nodules. And
Agreed, but I just wanted to give an example that's really strong.
I know, but for us, for users, for clients, and tomorrow we'll talk about this, the presence of minimal or incipient interstitial lung disease, bronchiectasis, mucoid impaction, a lot of signs that we're seeing on CT scans on patients who are getting screened or individuals who are getting screened are very important. And what I heard Tony Reed say this morning, I think is key. And, he was saying that for each different finding, we need different
Agreed.
Management of the devices. And that is for, we're assuming that is being done, but apparently it isn't.
Well,
So
Yeah, I'd like
mention
to
when we
comment.
need a standard. We need a standard if we go to ultra low.
well,
Because I'm
so-
not sure, I've been reviewing papers that are sort of trying to go to the X-ray dose for a CT. And we do see a spread in quality, sometimes within the same vendor. One of the
Yeah.
issues clinically is usually your patients will be predominantly scanned on the same instrument, or you're looking for things that are not as landmark. If they're sick,
Right.
we accept lots of crap.
Okay,
Excuse
so,
my
so
French.
let me ask Phil Judy. Phil, what's your experience with resolution on CT scanners?
Well, I guess my concern is not so much the nodule, but airways. That's an issue that's important in CPOD.
Agreed. So have you had issues with resolution not being a standard when you're trying to come up with better COPD methods?
Well, not really.
Okay,
I think it's the noise that's the issue.
I see. Well, it's true that different, and that's what Javier was saying, and we all agree, I believe, that different applications have different things. But again, I would just, we're working in a very difficult way because no presentations have been given. And unfortunately, I
But
think,
Rick, sorry, this is Raul. I think we should frame this a little bit because, I hear, obviously the unsettling from Javier saying, hey, as a clinician, I trust this, and now you're telling me not to trust this. I think one important aspect here with respect to a standard is that, then, for example, density, densitometry is something vendors calibrate against, because there is a common reference, so to speak. Resolution is very important, as you said, for specific applications, sizing, especially metrology, but obviously, let's not forget, it's something that changes. There is a knob there that protocols, radiologists use to
Yes.
modify that at will. So, in one hand, we cannot speak of a standard resolution because there is not.
no, that
Resolution-
wasn't the point. That wasn't
Yeah.
the point. The point
It's
was to
something
come
you
up with
got,
a standard for measuring resolution.
Yeah, the question is then, how we qualify the resolution of a scanner so we can specify the performance parameters of that. So
Yeah.
I think, and that is what I think you are heading to, and obviously variability across the spatial variability of resolution and the impact of the measurements. I think there is an important point, more even if you think of new approaches. Some of them we're doing in the lab that it tries to harmonize resolution. Not that indeed
Yes.
is to the point you are getting to. Like, can we truly harmonize resolution so then we come into sort of an equal setting for all the brands? No, but
Well-
that's, to me, that is kind of a further down the line topic. The question to you or the group is, okay, where is then the focus? Because I feel very unsettled saying we don't have a way to, we need a standard to measure resolution.
There are lots of ways. There are lots of ways.
Yeah.
There are no standard. There is not an accepted standard way. That's
So
why.
But where I'm coming from, Rick, is I think this group will be always very weak in setting that standard because we by large we are not physicists. No, I mean, and I'm speaking of my own weaknesses. No, obviously Phil is probably the most outstanding physicist there with early work in resolution. I'm saying that maybe we are not the right group to set standards around.
This is not asking us to set a standard. This is recommending that an open, collaborative, multidisciplinary group works on creating a standard. That's all it is.
Yeah. So, I guess what we're coming to is that this is a context-driven motivation for accepting this proposal. I accept this proposal. This is great. I'm a physicist. I'm going to be doing numerical calculations, and I want a standard MTF measurement so that I can do harmonization between different measurements later. And that's a really, really different interest than someone in the reading room with a patient in front of them.
Right.
I also support it.
This is the technical working group. So we have precedent here for focusing on the technical aspect of this.
I think, Ben, you were going to say something. I know you put something in the chat.
Yeah, I think it's not to say that the results that have been produced so far can't be trusted. It's that everything that we've been doing is this sort of background source of variance and noise. And it's in some sense independent of the scanner settings that we usually select on. You know, we talk about slice thickness, and we know there's been some study around the effects those have on all sorts of endpoints. But without any sort of at least agreed upon thing that we're going to compare to, it makes it difficult to harmonize between data sets. And no, I agree, Raul, that we are the wrong people to make the recommendation itself, but we are stakeholders in that recommendation because we develop the endpoints that will only come to be understood as validated if we can identify the sources of technical error and at least have some sort of, you know, notional sense of a solution or standard that we're going to agree on. That's what I have to say.
That I think the application we're looking for is in precision and repeat measurements. And the nodule is a classic. Here's a small object that we want to measure it multiple times, see what changes are. But I do think that's a very general kind of need for disease progression. And that right now we have an idea from the physics of how precise the CT scanner should be able to meet that goal. But we have absolutely no calibration and a suspicion that without any kind of calibration evidence whatsoever from the manufacturer, we're not getting what that machine is capable for these types of applications. This is not where the radiologist is making an observation of an image. This is where we have some kind of analysis algorithm that is trying to find out between multiple scans what's going on with the patient. And that's always going to require to try and reach the precision that the machine is capable of. And with absolutely no standards there, we are defeated before we begin.
Okay, we've spent too much time on this one topic. I think we heard a general consensus. If you feel we heard otherwise, let me know.
I mean, Rick, I would say there's probably universal alignment behind the intent of this. And I think people are just sharing different perspectives on either personal experience or how you would see motivating the quest to achieve this, if that's maybe the best way to say it. So,
well, you know, what I would envision here is that a general recommendation that a standard for 3D resolution is, let's say, desired.
Yeah. No, I think that's a very fair thing, right? Why not ask for as good as you can get? I mean, don't accept. Yes.
Okay, so moving on then, we have two panels, and one is on combined low-dose lung screening and COPD, a protocol for both of those. And we sent out questions. I don't know if everybody got a chance to see them, but you can see this here. So what I'd like to do is, if George and Javier agree to spend the bulk of the remaining time on this. The first question on this topic is, what are the clinical application targets of a combined CT image acquisition protocol for both lung cancer and COPD? So for example, we're going to do early detection of lung cancer. We're going to need to measure the nodule size over time. So that's going to bound our requirements. And then on the COPD side, are we just talking about being able to measure emphysema? Are we talking about wall thickness? Are we talking about other types of things? And the more we put in here, the harder it is to come up with a combined CT image acquisition protocol. So I guess, George, do you want to start off with some thoughts on that?
Well, I might start by punting it over to Javier because he has some slides addressing this exact thing for tomorrow. And so I think he has put the most thought into it.
Okay.
Okay, well, first of all, I think, we've been hearing COPD a lot and only COPD since this morning. And COPD is such a complex disease. We cannot bring it down to just, let's detect lung cancer, let's do lung cancer screening and COPD screening, because I think that is, first of all, it's beyond the scope of a CT scan. I mean, the CT scan can detect emphysema today. And we think, and there's been studies that correlate that with pathology, et cetera. COPD is a different issue. The COPD today is a standard. It's a definition by spirometry, by airflow, airway flow, and that's it. And so much research would have to be going, and of course George and Raul would be the ones who can address where the research is to be able to diagnose COPD as a standard as it's defined today. I think probably that's going to change. I think the gold criteria for COPD will change with all this in the future, but today that's what it is. So, and then there's so much more that we see on a CT scan related to lung diseases, not only in the world of COPD, but I said it before, interstitial lung disease. We're seeing in lung cancer screening patients early interstitial lung disease, and that is very important because that can uncover a whole host of things. And there's interventions for that. There aren't any interventions for COPD, early COPD, by the way. And actually the USPSTF recommends against doing screening for COPD. But pulmonary hypertension, measuring the pulmonary artery, for instance, that's very important.
So are you advocating then that we don't try and create a combined lung cancer screening and COPD imaging protocol? Or are you saying it has to include interstitial lung disease? What's your proposal?
That I don't think we're at a point where we can actually write a protocol to do that yet. I think these are aspirational questions and obviously very desired. I mean, I think we've done a lot of work on on emphysema and lung cancer risk and all that stuff. So yes, we should be able to. I, as a clinical researcher, should be able to trust the CT scanner when it tells me that there's emphysema there and what degree of emphysema. I need that, but I don't think we're at a level where we can right now write a protocol, a combined protocol for diagnosing nodules and COPD.
Why do you say that?
Because there is no good correlations between CT findings and COPD.
So let's say
as defined clinically today.
So let's say we step back to lung cancer screening and emphysema. Can we not create a protocol that handles that does a good job of giving us both? Okay.
So then I would raise a question. There are many studies, and we have done a few of these, showing that the presence of emphysema is associated with increased risk of lung cancer. Only when you do it visually. When you do it with all the software, automated software, that association is not found until right now. Just the last paper that came out that did find it. Why is that happening? Are we ready to write a protocol for that?
We don't even know if the scanners are giving us consistent enough information for that to work.
Okay.
So, but actually the lung density group in Kiba has spent a lot of time on this. So George, do you want to say something about that?
Yeah, something, and then I want to, again, it looks like Ben unmuted, and so I'm interested in, and he had mentioned about moving technology into the clinical space, but I may be sort of echoing Javier's statement that part of the frustration of COPD is that so much of what is there is not modifiable by current technology. And so there are features, comorbidities, bronchiectasis, coronary disease, pulmonary hypertension, other other pulmonary and extrapulmonary manifestations that I think we can intercept and actually modify disease trajectory. The one that we're focused on here, emphysema, is the one that's probably the most challenging because as of yet, we have nothing that works. And you could say,
I guess we had this discussion at the last quantitative imaging workshop. If a person has emphysema and they're working in an environment that we know has a impact on emphysema, a negative impact on emphysema, why is it not okay? Why is it not a good intervention to suggest that they get out of that environment?
Oh, it is, but I think this comes back to maybe a point that even Tony made earlier, that what degree of accuracy and precision do we need to make that recommendation? If we see holes in the lung, we don't need anything better to make that decision. But maybe I again, Ben, I saw you on mute, and I'm interested in hearing your opinion on that.
Sure. Yeah, so I mean, and it should be stipulated that I am not a physician. But I'm familiar with the literature surrounding sort of the detection and the problem with emphysema in the context of patients without like spirometric airflow obstruction. And I think that I understand that it is a troubling thing to have a finding that you cannot intervene on and that has questionable clinical relevance in the future. And I do think that that's important, but I also think that it's a somewhat self-defeating attitude to maintain, because we know, and this is sort of not a unique feature of respiratory disease, but a particularly salient one, that by the time they become symptomatic, most of the pathology is done already, right? Like by the time, I mean, I think pH is an extreme example in the sense that like, it's actually after the whole, half the vascular bed has been impaired. And it's not only then, but rather when the right ventricle begins to decompensate, right? It's so late. And at some point, you have to, if you have a way that could putatively provide information about early onset, like there has to be some acceptance of slightly higher risk to detect that, right? Like, and I think this is probably the only way that could ever plausibly happen, right?
No.
Well, don't forget,
David, I mean, if I can add, Rick, just one thing. I mean, and let me say that from the beginning, I am for screening, not screening, but screening for lung cancer, and we're detecting emphysema on 30% of our participants. Most of them don't know it, as was mentioned this morning. That has been shown in many studies already before. And by the way, 20% of the patients with emphysema do not have airway obstruction by spirometry. So I think it's very important to detect emphysema, but and there is an intervention that I think the USPSTF is missing. And that is, if you have somebody with emphysema, you uncover unknown emphysema, you know that person has a 3-fold increased risk of lung cancer compared to somebody who doesn't have emphysema and has smoked the same amount. So yes, there are ways of intervening, not only smoke and cessation. Naysayers will say everybody has to quit smoking, not only patients with emphysema. So that's not a reason, but you do know that patients with emphysema have an increased risk of lung cancer. So solely only for that reason, I am interested in knowing that a patient has emphysema. So yes, we should write recommendations in that sense, I think, or we could, but I don't think that we can write a protocol which includes the words lung cancer screening and COPD in it yet, because
no, Javier, the goal here is to refine this word COPD. So if we replace that with emphysema, are you happy?
Yes, I would be much happier with only emphysema, but again, there's still a lot of work to do to define how do we define emphysema, degrees of emphysema, paraseptal emphysema versus centrilobular emphysema. We also published that paraseptal emphysema is not associated with an increased risk of lung cancer. The centrilobular and panlobular emphysema, they're probably two completely different diseases. So it's not that simple.
Yeah.
And we're not trying, well, hold on a second. We're not trying to solve it here. we're trying to come up with recommendations to pursue things like,
Okay.
like a common image acquisition protocol for lung cancer screening. And let's just call it emphysema.
Okay, that's good.
But I want to something to add because might help to guide this, and I think I definitely like, for all the reasons stated, moving in this direction. And Ben put it very clearly, from the technical end. But probably where we are lacking here, when we want to do a protocol, we have a protocol, combined protocol for lung cancer screening, a very actionable item, and then COPD. But COPD, what is that? I mean, are we diagnosing COPD? Are we, defining comorbidities? So probably what we are lacking here is where are we intending to use, or to do with this combined protocol? And I think Javier is bringing excellent points around comorbidities, as a key pillar of lung cancer screening itself. Then we have the topics around population management that were discussed this morning. So I think as a group, what I'm lacking now personally, and I think as a group will help, is in really narrowing down what precisely we want to do with this combined protocol in these other aspects. We want to just detect comorbidities as modulators of lung cancer risk. I think to me that is a very valid proposition that will probably get us where we want to go. We get us to define probably the protocol that meets the requirements, but also doesn't stretch itself to, maybe put into the table an issue that might be more problematic than, helpful. So again, I think that will be important, to really truly narrow down the need of the combined protocol, and then what is precisely, that combined protocol.
Yeah.
Right. Okay. That's good. That's a good point. I wrote it down. Let me ask a question because there was discussion about sort of inspiratory and expiratory sort of respiratory phase. So just a curious question I have to you guys. Is there, for emphysema measurement, is there a preferred respiratory position that would work in a screening setting, a lung cancer screening setting?
I think for emphysema, it's inspiratory, right?
Yeah, it would be the same as for a lung nodule.
Yeah.
Same as for a lung nodule. Oh, so we have good.
Yeah.
Okay.
Yeah. So Rick, if I can quickly circle back, I actually think our failure to address the common protocol is part of the reason why we have no therapies for disease. Okay.
Wow, that's a strong statement.
Well, and so we'll have Ruth Telsinger talking tomorrow, who's she's an expert in drug development, came from GSK, is now leading the COPD Foundation. And she has been leading the charge to have densitometry as a registratable endpoint for therapeutic intervention, right? So this is the whole effort of the CBQC, the COPD Biomarker Qualification Consortium. And the limiting step is that we lack the precision of measurement, the reproducibility of measurement to design small pragmatic trials with therapies to see what slows the progression of airspace dilation. And so the respiratory community in biopharma have largely abandoned this because they don't want to do a 1,000-person study, right? They will do 100-person studies all day, but a 1,000-person study is too massive an investment for something that's so high risk.
I completely agree, and I want to get your full quote when I get a chance. So,
Okay.
I thought it resonated. I think we're almost out of time. I forget what the schedule says. I don't know how people feel about staying on.
You have until 5:45, Rick.
Oh, okay. So, I don't know, George, Javier, any question out of here or that you can think of you might want to add to this? So let me just add that I'm leading an effort to create a manuscript, which will involve a lot of work, and that provides a common protocol for both lung screening, and let's call it emphysema so we don't get Javier too upset. And which is where I thought it would land anyway. But so this is happening, and there's a lot of people involved already. So anything we can do here as a recommendation will go straight to a group of people who are actively working on this. So again, Javier, George, do you want to add some more sort of thoughts to what we should do or not do in this space?
Well, again, I would add the other pulmonary diseases that, detected pre-symptomatically can, we can have an impact, and there are interventions available already. So, they would be more actionable than COPD, for instance. And we're going to talk about that tomorrow, and I hope in the panel. But so I'm worried what Tony said this morning about, you need different calibrations for bone density versus emphysema, or for
it's true, but there's a lot of overlap. Okay, so it's not the case that you need one completely different set of things to worry about for lung nodules as you do for ILD, for example. There's a lot of commonality. The fundamental physics and the first, basically the optics are very common. There might be more emphasis on one thing or another, like noise might be more important in certain situations. Like if you're looking at textures, noise is a really big deal. But if you're looking at high contrast objects like small lung nodules that are solid, noise doesn't play as big a role because the contrast is so high. Anyway.
So I think it's important to standardize, and maybe this is not technical. Maybe this shouldn't be in this discussed by this group, but reporting of findings like bronchiectasis, which is very common. We're also finding that very frequently on screening CTs. Is there a standardization on how to measure or how to diagnose bronchiectasis on low dose CTs? That I think is important. Many other findings that maybe it's not the moment to discuss, but
okay.
And I think I totally agree. And with all of this, as we're thinking about a standard protocol, and what we want to really get a sense of now that we have the tools to make such measurements, we want to understand disease activity. So is there a progression of those fibrotic changes in the peripheral basal region, right? So there are drugs for that. In the certain people that are actually having progression of fibrosis, let's not wait in 10 years. Let's sort of wait a year or less, right? Emphysema, it would be good to know who has progression of the airspace dilation. We don't have a drug yet, but if we can understand the heterogeneity and disease activity, that will inform many downstream things. So I think we have been using blunt tools and sort of a clinical eye to extract a lot of data, but it would be exciting to see how much more you could push things, right? And there will be things that say, that didn't make a difference at all. And there are other things that I think we'll be surprised by. So I think we should definitely advocate for this.
I agree. I think we have an incredible tool. I mean, that sees the disease and that can see the changes. That's better than any blood test for sure. So, it's you are the people who have to come up with the standards to be able to measure those changes, because we're really eager to have that tool. Because just with one test, I mean, look, cardiology has already taken advantage of the findings of with the coronary calcium, and they're really acting on it. We've been discussing about this for decades, and usually cardiologists beat us on that kind of implementation of things.
They always do, yeah.
So some of you may have heard that as part of KIBA, we created a guidance document for COVID-19 quantitative imaging applications. And one of the best, in my view, best parts of that guidance document was that we looked at all the image quality data we had and the analyses we've been doing over 10 years. And we came to a consensus on recommended reconstruction kernels. And so what this does is it helps the field sort of focus on a few standard kernels, not to promote GE, but because that's the name of their kernel, but what it does is it says, hey, we're the quantitative imaging community and we're relying on these kernels right here to remain stable and to do the right, to exhibit the kind of qualities that we expect, not high levels of edge enhancement, not, there's no guarantee that a kernel can't change from one year to another, one day to another. But we would like there to be stability on these types of kernels. And if we can come up with better kernels, that'd be great. But trying to get all the vendors to provide, get together and come up with a standard kernel that works across all of them, I think that's a noble cause, but it'll never happen, I don't believe. So anyway, I just want to point out to you, we've got a little bit of experience in doing this. And we do have this really nice output that came out earlier this year. And one of the goals here is to replicate that for lung cancer and COPD and emphysema.
So Rick, why can't those same recommendations for kernels be directly applied to screening for emphysema? I mean, we're interested in probably much more so in the precision than the accuracy of these things, right?
Well, I'd like to, I think when we get together and we put together all the requirements, what you said might lift out of that analysis, but I'm not sure if that's true.
Okay, no, that's fair.
Remember, we can't forget about the small lung nodule measurement over time, right? So we have a difficult task of basically supporting both types of measurements.
With
all right,
different properties, yeah.
Let's open it up to other people we haven't heard from. Any thoughts?
Hi, Rick, this is Dan. I would like to make a couple of comments if I could, which are a little different direction than
Sure.
what's gone so far, but it relates to your questions that you have here. And so I know this is the technical group, and you've done a terrific job for many years focusing on this, and that's your background, your expertise. But you have opened up the topic a little broader by the way you worded your questions, I think. So question number 2 says, what studies will be necessary, blah, blah, blah. Question number 3 says, do we have enough data? And that implies studies. And question number 4 says, what's the best way to achieve acceptance, which I think implies more data. And a couple of comments just to support that before I make my point. When you earlier asked about the standards, I think George Washko said, well, why don't the manufacturers do this? And one of the responses back from the manufacturers, well, our customers don't ask for this. And the reason they don't ask for this, I think Francine sort of touched on this, and this is not a criticism at all, but she sort of said, I'm paraphrasing, well, I'm not sure that I'm not convinced as a radiologist that I need this level of increased resolution. I'm not sure it makes a difference. And Jim Mulshine in his presentation this morning quoted some random anonymous radiologist, and he said, why incur the potential cost and additional effort to use quantitative analysis? So I think there is a general concern amongst radiologists, a resistance that they're not convinced that this would make a difference. And so all of this comes back to potentially the need for data. And we hear this a lot from people saying, show us that it makes a difference, that we can accurately measure 6 millimeters versus 5 millimeters. This is, potentially a huge deal. I mean, it would be potentially a large trial. But the reason I'm throwing this out is because you have raised these questions, I think, essentially here in your questions. And I wonder if the Prevent Cancer Foundation could focus a little bit more on this issue. How might they help to develop, to not to conduct these kind of trials, as they don't do that, they don't have infrastructure, but could they be a collaborator? Could they pull groups together? Could they help to create, produce, facilitate the clinical trials that would be needed to collect this kind of data? And I'm thinking, for, as an example, the Cancer Prevention Division at NCI a couple of years ago funded this huge trial, took a couple of $100 million to test tomographic mammography screening. And people have said this is a huge waste of public money. It's obvious that there is a slight increased benefit of tomography and mammography, and departments are going to migrate over. The results of this trial are not going to change anything. People are going in that direction. So there's potentially money that could be done if they were persuaded. They were persuaded by a variety of groups. Anyway, I'm throwing this out as this is not something that that you can deal with in this last minute, but I think it would be worthwhile for this Prevent Cancer Foundation to think about what role they might have in this.
I think it's very important what you just said, Dan. Thank you.
So a couple of things, Dan. This came up during the planning session. Actually, Ella Casarini was pretty strong about this. And the moment I said, let's do a study, which is exactly what you said, she kind of backed away. And I wasn't sure why. I have to ask her. But the point is that not only, okay, a study would be a big enough study would be a big effort. But we have tons of data on the quality, mathematical descriptions of the acquisition systems from all over the world and all kinds of protocols. And we can combine that with simulations and modeling to at least give an initial assessment of where we think, what we think the impact, the effect size is going to be. So I would recommend that we do that step first, which is what we're doing really. And we can show what the difference is with regard to having tight control over your quality of your images versus having the current status, which is not a lot of control. Does that sound like a reasonable path, Dan?
I think it would be terrific. Whether it would be enough to convince radiologists, I don't know, but I think it's an excellent idea and potentially a good direction to go.
Well, the hope is that if it doesn't convince the radiologists, it convinces the funders of clinical trials and studies who might want to settle this.
Oh, yeah.
And Rick, we do have to be careful of the messaging around this, because
Yes.
if we come out with, we say we're 10% better at predicting who's going to die of their disease, people go like, wow, okay, what do we do? But it has to be something, you have to have an actionable observation from this.
Of course.
It can't simply be a better tool for stratification, because you also, for the adoption of this, there has to be some incentive other than just improved understanding of disease, right?
I think we've always, well, I could be wrong, but I think we've always strived for that. But it's good to be reminded.
No, and I'm not discounting the effort. I'm simply saying, just in the messaging around this, and who is the consumer of those results, right? Because who is the actual driver of the decisions to get these tools into clinical settings?
Right. Any last comments? We've covered a lot of ground, and actually, I commend the group for how much we got done in this one session.
I think it was a great session. I think it's a great setup for tomorrow. I was kind of interesting, Rick, in seeing how you're going to chaperone us through this anticipatorily, hoping everyone read maybe the itinerary for tomorrow. So
I apologize if I pushed too fast and too hard. I just wanted to get us past the finish line. I think the right thing to do at this point is to take the notes. I think there's a recording of this. I work with George and Javier mainly overnight and see if we can agree on some slides. And then you can all beat us up if we get it wrong. How's that?
Thank you, Rick. Good job.
All right, thank you all.
Masterful. Thanks a lot, guys.
Thanks, guys. Bye-bye.
Thank you.
Yes.